Let's dive right into something truly spectacular, what I like to call the Master Detective's Toolkit of non-invasive cardiac imaging. We're talking about the absolute engineering marvels that let us peer deep inside a beating human heart to understand its structure, its function, and its blood flow, all without making a single surgical incision.
And honestly, understanding the heart has never been more critical. Every single year, cardiovascular disease claims an estimated 19 million lives globally. It's the leading cause of death for both men and women. That staggering statistic right there, that validates exactly why mastering these imaging tools matters so much. Because by visualizing the heart's inner workings early and accurately, we can identify risks, guide treatments, and ultimately save a lot of lives.
So to do that, modern medicine relies on a highly specialized toolkit. In this explainer, we're going to unpack this toolkit modality by modality. First up is echocardiography and how it uses sound. Next, nuclear imaging and glowing tracers. Then cardiac CT with its rapid X-rays. And finally, we'll wrap up with cardiac MRI and magnetic protons.
Let's start with the first and definitely the most widely used tool in our kit, echocardiography.
Okay, so let's get into the physics here. Echocardiography uses high-frequency sound waves, ultrasound, to penetrate the body and reflect off cardiac structures. You have an electronically steerable phased array transducer that emits these ultrasound sequences from piezoelectric elements. When those sound waves bounce off the heart and return as echoes, the receiving elements sense them. Then, microprocessors take the timing and the magnitude of those returning echoes to generate these incredibly detailed, moving two-dimensional images in real time. We're talking about capturing more than 30 frames every single second.
But here's the thing. Sound doesn't just show us structure, it shows us movement. Echocardiography uses the Doppler principle to measure the velocity of blood flow. Think of a passing siren. As it moves toward you, the pitch gets higher, and as it speeds away, the pitch drops, right? Well, similarly, when ultrasound reflects off moving red blood cells, there's a frequency difference between the emitted and reflected sound. We use that Doppler shift to calculate exactly how fast blood is moving. And that data lets us precisely calculate the pressure gradients between heart chambers and across valves using the modified Bernoulli equation.
And the engineering has become so advanced lately that these machines are literally shrinking. We now have point-of-care ultrasound, or POCUS equipment. These are pocket-size units offering diagnostic quality imaging that doctors can just carry around on rounds, bringing this massive technological power directly to the patient's bedside for immediate answers. The everyday utility of this tool is just immense. Think of it as the frontline defense for assessing systolic function, like figuring out the ejection fraction, to see just how well that left ventricle is pumping. It lets us evaluate chamber size, quantify how severely a valve might be narrowed or leaking, and when we use a specialized transesophageal echo probe down the esophagus, we can easily spot small, dangerous lesions like blood clots or infected vegetations right on the valves.
Now let's transition to the second tool in our kit. Number 2 is nuclear imaging, the metabolic and molecular tracker of the heart. With this, we can actually visualize blood flow using chemistry by intravenously injecting small amounts of radiopharmaceuticals. Think of these like glowing breadcrumbs. These tracers, like rubidium-82 for example, travel through the bloodstream and get trapped inside the heart's cells. As they decay, they emit gamma rays. Specialized scanners then detect those gamma rays to build a tomographic, three-dimensional map of blood flow to the heart muscle. So there are two main types of nuclear scanners we use, SPECT and PET. SPECT is the most widely used and typically relies on tracers like technetium-99m, but PET imaging is increasingly favored because it offers significantly better spatial and contrast resolution. Plus, PET provides absolute quantitative measures of myocardial perfusion, measured in milliliters per minute per gram of tissue. That greatly improves diagnostic accuracy, especially if you're dealing with high-risk or obese patients.
The clinical payoffs here are huge. We often combine this imaging with exercise or pharmacologic stress to evaluate coronary artery disease. If a patient has a normal scan, it effectively excludes myocardial ischemia and predicts an incredibly low rate of major adverse cardiac events. We're talking less than 1% annually. Beyond coronary disease, we use specific tracers to detect heart inflammation, check if damaged heart muscle is still viable enough for bypass surgery, and even diagnose specific conditions like cardiac amyloidosis. Moving right along to build out our diagnostic picture, we turn to our third tool, cardiac CT. This is the ultra-fast, high-resolution slicer of the toolkit.
The engineering required to image a beating heart with X-rays is just awe-inspiring. I mean, to prevent a blurry image, the heart essentially has to be frozen in time. First, we slow the patient's heart rate down, ideally below 60 beats per minute. Then, we give nitroglycerin to open up the coronary arteries. We inject an iodinated contrast agent to make those blood vessels really pop. And finally, we use the patient's own ECG to trigger the X-ray snapshot at the exact right millisecond. That entire three-dimensional dataset, it's acquired in just 5 to 15 seconds. Now, crucially, we can use CT both with and without iodinated contrast. A non-contrast CT allows us to perform calcium scoring. By detecting bright white calcium deposits in the coronary arteries, we can directly quantify a patient's burden of atherosclerosis. An Agatston score over 400 is considered severe, and that directly links to a significantly higher risk of cardiovascular mortality.
But when we do use contrast for a CT angiography, we get an incredibly detailed look at the vessel lumen itself. Why does this matter in the real world? Because coronary CTA has an extremely high negative predictive value. If a patient shows up in the ER with acute chest pain and they have a clear CT scan, doctors can confidently rule out obstructive coronary artery disease and safely send that patient home without needing more invasive tests. It's a real game changer. And that brings us to the fourth and final tool in our non-invasive kit, cardiac MRI. This is the magnetic marvel of modern medicine, and a huge bonus here is that it doesn't rely on any ionizing radiation at all. Cardiac MRI operates through what you can think of as a synchronized proton dance. Because the human body is mostly water, it is absolutely full of hydrogen protons. Inside the MRI's powerful magnetic field, these protons perfectly align. We then deliver radiofrequency energy pulses to specific planes of the heart. The protons absorb this energy, and when the pulse stops, they release the energy right back. Receiver coils collect that signal to form highly detailed images. And because different tissues, like fat, muscle, or fluid, react at unique frequencies, we extract stunning contrast between different structures. One of the absolute most powerful specific techniques in cardiac MRI is late gadolinium enhancement, or LGE. Basically, by administering a gadolinium-based contrast agent and waiting just a short bit, the contrast washes out of normal heart muscle but gets trapped in expanded spaces, like scar tissue. This allows doctors to pinpoint exactly where the heart muscle has been infarcted, scarred, or damaged by infiltrative diseases. Cardiac MRI simply offers supreme tissue characterization. Take cases of severe pericardial disease, for instance. We can clearly see a thickened pericardium, that's the sac surrounding the heart, and any fluid trapped within it, with a level of clarity that is often really hard to match with other modalities. So let's synthesize what we've covered today. This Master Detectives Toolkit is wonderfully comprehensive. Echocardiography uses sound for highly accessible real-time functional assessment. Nuclear imaging uses gamma-emitting tracers to track metabolism and blood flow. Cardiac CT relies on rapid X-rays, synchronized with the ECG for high-resolution coronary anatomy. And cardiac MRI uses magnetic fields for unparalleled tissue characterization. Each modality brings a unique, highly complementary piece to the diagnostic puzzle, allowing physicians to precisely tailor their approach to every single patient's heart. As we look at the rapid evolution of these tools, with ultrasound shrinking to fit right in our pockets, and artificial intelligence stepping in to help interpret these complex images, it leaves us with a pretty provocative question. Will the traditional stethoscope soon become a relic of the past? Thank you so much for joining me for this explainer today. I hope this journey through non-invasive cardiac imaging left you with a deeper understanding and an eagerness to see where the future of cardiovascular medicine goes next.